Hello everyone, this is Dr. Govind Raikar. In this video, we will discuss the drugs and hormones that affect the calcium balance. Basically, we will go to treatment of osteoporosis. Now, we all know three main hormones or three main substances which control calcium and phosphate. Calcium and phosphate. These are vitamin D, calcitonin, and parathyroid hormone. Now, if we revise, what is the effect of vitamin D on serum calcium and serum phosphate? Vitamin D, it increases both. Calcitonin, it decreases both calcium and phosphate in the blood. Whereas parathyroid hormone, it increases calcium but it decreases phosphate. Now, as we are going to discuss mainly osteoporosis, so we are concerned with calcium. So, for the time being, we will forget the phosphate part. We will limit our discussion to calcium part. But be very careful, we are talking about calcium at which place? It is in the blood, serum calcium. So, vitamin D and parathyroid hormone, they increase serum calcium, but calcitonin decrease serum calcium. So, which out of these we can use in osteoporosis and which will be avoided? We cannot comment because we need to know what happened to bone calcium. Only then we can tell. So, we need to understand how they affect blood calcium. Only then we can tell whether we can use the drug in osteoporosis or not. Okay. Vitamin D increase blood calcium. How it increases? It acts by increasing the absorption of calcium and decreasing the renal excretion of calcium. So, from the GIT more absorption occur, from the kidney less goes out, so more remains in the blood. So, when more calcium remain in the blood, more will go to bones. So, it can treat osteoporosis. So, vitamin D is used in osteoporosis. Okay. On the other hand, calcitonin and parathyroid, they have opposite effect on calcium. But how parathyroid hormone increase calcium? It also increase calcium. But the mechanism is totally opposite. Parathyroid hormone, what it does is, it causes resorption of bones. Resorption of bone means it brings calcium from the bone to the blood. So, there will be more calcium in the blood. But what happened to bone? Calcium decreases. So, rather parathyroid hormone cause osteoporosis. Okay. And calcitonin do opposite. That means from the blood, it moves the calcium to the bone. So, from the blood, the calcium go to the bone. So, it will be more in the bone, less in the blood. So, it can also be used in osteoporosis. So, we can use vitamin D and calcitonin in osteoporosis, but hyperparathyroidism is a known cause of osteoporosis. Okay. So, coming to our main topic, osteoporosis. So, obviously, osteo means bone, porosis means pores. Because of less calcium, bone become porous. So, what we do, obviously, we can give calcium. Because it is due to deficiency of calcium, we have to give calcium. Apart from calcium, we discussed two drugs just now. One is vitamin D and second is calcitonin. These we can use in osteoporosis. Calcitonin is given by intranasal route for this purpose. Then, which diuretic you can use in osteoporosis? Yes, these are thiazides. Thiazides are the diuretics. Remember, loop loses calcium. Thiazide retain calcium. So, when calcium chronically increase, we can treat osteoporosis. Moving to the most important drug in osteoporosis, this group is called as bisphosphonates. Bisphosphonates. The drugs examples are alendronate. The name end with the dronate. Alendronate, risedronate, and zolendronate. Name end with the dronate. Now, how these drugs work in osteoporosis first? In the bone, we have two type of cells. One is called as osteoblast and second is called as osteoclast. Function of osteoblast is to form bone formation, whereas function of osteoclast is to cause resorption of bone, or we can say bone eating. So, for treating osteoporosis, we have two mechanisms. Either a drug may stimulate osteoblast or the drug may inhibit osteoclast. Yeah? And bisphosphonate, they work by inhibiting osteoclast. So what they do is they help in inhibition of maturation of osteoclast. Immature osteoclast cannot become mature osteoclast, so bone resorption will not occur. And the mature osteoclast, they get apoptosed. It results in apoptosis of mature osteoclast. So in simple language, it inhibits the function of osteoclast. So when osteoclast do not work, bone eating will not occur. That means the formation only occurs that will treat osteoporosis. From the name itself, you can remember the name itself says dronate, look like do not eat. Yeah? So it inhibits the eating of bone, do not eat. Yeah? So they are used in osteoporosis. Now special thing to remember, bisphosphonates are drug of choice for osteoporosis. When we say they are drug of choice, means they are drug of choice for osteoporosis due to any reason. They are drug of choice for postmenopausal osteoporosis also, steroid-induced osteoporosis also, or osteoporosis due to any reason. They are drug of choice. Now, among the bisphosphonates, alendronate and risedronate are given orally, whereas zoledronate is given by intravenous injection. The question is there any sense of giving intravenous drug for a condition like osteoporosis, which is a prolonged condition? Obviously not. We want a drug to be given orally for such a condition because we have to treat for long periods. Now the question is, why we have approved the intravenous route then? The reason is zoledronate is very, very long acting in bone. It gets concentrated in the bone, and a single intravenous infusion keep on working for 1 year. So it can be given once yearly for osteoporosis. Obviously once in a year we can give IV. So it is given once yearly intravenous infusion for osteoporosis. Okay. So the first use is they are drug of choice for osteoporosis due to any reason. Second, they are also drug of choice for hypercalcemia of malignancy. Hypercalcemia of malignancy. First of all, what is the meaning of this? Hypercalcemia of malignancy. The name tells in the cancers there is hypercalcemia. The first question is, why hypercalcemia occur in malignancy? What is the most common reason? The answer is not paraneoplastic syndrome. Do every malignancy has paraneoplastic syndrome? Obviously not. Only few malignancies. But hypercalcemia can occur in almost any malignancy. Then how it happens? The simple answer is metastasis to bone. The cancer cells, they metastasize to bone and they produce osteoclastic secondaries. Simple language, they will stimulate osteoclast there. When osteoclast is stimulated, calcium from the bone comes to the blood, that lead to hypercalcemia. So when there is hypercalcemia due to osteoclast, obviously we will want to inhibit osteoclast, and bisphosphonate do the same thing. So bisphosphonates are drug of choice for hypercalcemia of malignancy also. Okay. Then they are used in early stages of Paget's disease of bone. Remember, Paget's disease is of bone also and breast also. We are talking about bone. In Paget's disease, initially there is stimulation of osteoclasts which lead to bone erosion, or we can say osteoporosis. But in later stages, osteoblasts are overworking that lead to osteosclerosis. Okay? So in early stages it may be useful. When osteoporosis is there, osteoclasts are overworking. Okay? So these are the uses of bisphosphonates. Now coming to its problem. The major and the most important adverse effect of bisphosphonates are esophageal ulcers, or we can say esophageal toxicity. Bisphosphonates are highly toxic to esophagus. If they touch the esophagus, they can cause ulcers. And except zoledronate, that means risedronate and alendronate, they are given orally. So when we give them orally, they can touch the esophagus and that can lead to ulcers. So how to prevent that? So whenever we give bisphosphonates, we give some instructions. 3 important instructions we give are: number 1, take them empty stomach. Number 2, take with full glass of water, not little bit, full glass of water. And number 3, do not lie down for half an hour. Now, why these 3 precautions are taken? The first thing, why the person should not lie down? The obvious reason is if the person lies down, there is more chance of drug touching the esophagus. But question is, does it take 30 minutes to pass the drug cross the esophagus? When we take anything orally, it has to cross the esophagus, which is only this much structure. So that will go in seconds. By gravity also it goes down. So why 30 minutes? So 30 minutes are not the time so that the drug can cross esophagus. The problem in esophagus occurs, the drug crosses easily. But the problem occurs when it regurgitates. If the drug goes back, then it will keep on touching the esophagus. So 30 minutes is the time which is gastric emptying time in which the drug has gone below the stomach. So now if the person lies down, there is no problem. Clear? So person should not lie down to prevent regurgitation. Same reason is for empty stomach. If the food is already present in the stomach, the risk of regurgitation is more, reflux is more. Clear? And full glass of water obviously to dilute it. Even if little bit goes back, if it is diluted, it will not cause that much problem. Okay, so these are the must know precautions for giving bisphosphonates. So esophageal toxicity. Then apart from this, bisphosphonates can cause osteonecrosis of mandible. Osteonecrosis of jawbone, that means mandible. It is a good, or we can say well known side effect of osteoporosis. Then lastly, zoledronate only, not all bisphosphonates, zoledronate, it can result in renal failure. Zoledronate is associated with renal failure. Okay, so these are the important points regarding the bisphosphonates. They are drug of choice for osteoporosis. Okay, then you must have heard about a term called as post-menopausal osteoporosis. You have heard about this term? My question is, the term says it is post-menopausal osteoporosis. That means before menopause, osteoporosis is not present. So what happened during menopause, that osteoporosis occurred. We know at the time of menopause, ovaries stop producing estrogen. So when estrogen is not there, that leads to osteoporosis. That means estrogen was protective to bone. Estrogen was preventing osteoporosis. When estrogen is not there, osteoporosis occurs. So when estrogen was preventing osteoporosis, then why not to give estrogen? So based on this, we thought about using estrogen in osteoporosis. But problem is, estrogen do not act only at bone. Estrogen act at almost every part of the body. So first, like to understand about actions of estrogen. We will discuss the effect of estrogen at important places. Then we will see whether it is good or not. So if we talk about estrogen actions at 5 places, one obviously is bone. Apart from that, blood, breast, endometrium, and liver. So you can easily remember estrogen increase something at all these places. Like it increase the formation of bone, that means prevent the osteoporosis. It increase HDL LDL ratio in the blood. HDL is a good cholesterol, so that means it has good effect on the lipid profile. It increase the risk of breast carcinoma. We know estrogen positive breast cancers are there. It increase the risk of endometrial carcinoma also. And it increase the formation of clotting factor through the liver. So that increase the risk of thromboembolism. So if we talk about estrogen in osteoporosis, but we know estrogen increase bone formation by preventing osteoclast again. So that means it is good for osteoporosis. In addition, it improves the lipid profile, another good thing. But the problem are these 3 deadly side effects. It increases the risk of breast and endometrial cancer. It increases the risk of thromboembolism, so increased risk of MI, stroke, etc. So all these are unacceptable. For just osteoporosis, we cannot take this much risk. We are not ready. So we do not use estrogen. But previously we were doing, which we do not do nowadays, we were giving estrogen in combination with progesterone. That combination was called as hormone replacement therapy. The question asked sometime was, why progesterone is added in hormone replacement therapy? We want estrogen, but why progesterone is added? The reason is progesterone has opposite effect on endometrial cancer. Progesterone decrease the risk of endometrial carcinoma, and when we give HRT, estrogen plus progesterone, the net effect is actually decrease in risk of endometrial cancer. Estrogen was increasing, but hormone replacement therapy is decreasing the risk of endometrial cancer. That means one adverse effect has been converted into advantage. Adversity has been converted into advantage. Okay? So progesterone was added because of that. But the problem was progesterone also increased the risk of thromboembolism a little bit. Progesterone increased the risk of breast cancer. That is the major problem. So increased risk of breast cancer is a significant side effect still. So we do not use hormone replacement therapy for osteoporosis nowadays. Then what is the solution? The solution is we want such a drug which stimulate the estrogen receptor in the bone, but do not stimulate in the breast or endometrium, etc. Okay? So we want some drug which has agonistic effect on estrogen receptor in some tissues and antagonistic effect in some tissues. So such a drug is known as selective estrogen receptor modulator, SERM. And the best SERM till now we have is raloxifene. Raloxifene. So raloxifene, it has almost all the advantages which we want, except only one, that is in the liver it is problematic. So if you see effect of raloxifene at first 4 places, whatever action we want, it has that action. We want agonist in the bone because we want to form bone. So it is agonist in the bone. We want agonist in the blood because we want to increase HDL-LDL ratio. We do not want breast cancer, so we want it to be antagonistic here. We do not want endometrial cancer, we want to be antagonistic here. So raloxifene has all these properties. It is agonist in the bone. It is stimulating the HDL-LDL ratio. It is antagonistic in breast and endometrium. But the problem is in the liver we want antagonist because we want to decrease clotting factor. We want to decrease risk of thromboembolism. But the problem is it is agonist in the liver. So the major adverse effect of raloxifene is thromboembolism. Thromboembolism. Yeah? So drug of choice for postmenopausal osteoporosis is very good. Answer is still bisphosphonates. Bisphosphonates are drug of choice. Raloxifene can be used. It is not preferred because of risk of thromboembolism. But if there is other risk factor like a female with osteoporosis has family history of breast cancer or endometrial cancer, then we can prefer raloxifene. Okay. So that is about the SERM group of drugs also. So now we will move to some new drugs in osteoporosis. And among the new drugs, the first one we are going to discuss is PTH 1234. So PTH is parathyroid hormone. But if you remember in the beginning of this video, we discussed that parathyroid hormone cause osteoporosis. So now we are saying that parathyroid hormone will treat osteoporosis. And how it is possible? The actual thing is parathyroid hormone, it consists of 84 amino acids. PTH, it consists of 84 amino acids. We can write PTH 1 to 84. This full molecule, it stimulates osteoclast. So that means it will cause osteoporosis, which we discussed earlier. But accidentally, once we noted that parathyroid hormone break into 2 components, the first 34 amino acid got separate and rest of the 50 amino acids, they got separate. And this smaller molecule, it was actually stimulating osteoblasts. Full molecule was stimulating osteoclast, but this smaller molecule was stimulating osteoblast. So when we came to know that it is stimulating osteoblast, we did not take any time and make this as a new drug which can be used in osteoporosis. And such a drug is teriparatide. And one more drug has been formed, abaloparatide. So from the name itself, you can remember it is containing parat in the name. That means it is parathyroid hormone. And it is ending with the tide, means it is peptide, so cannot be given orally. So these drugs are given by injection by subcutaneous route. So they can be used in osteoporosis, but special thing to remember, they act by stimulating osteoblast, not by inhibiting osteoclast. This is the first drug we are discussing that stimulating osteoblast. Okay, teriparatide group, this PTH analogs, they can increase the risk of osteosarcoma. Okay, so that was the first new drug in osteoporosis, teriparatide group. Then moving to second group of drugs in osteoporosis, new drugs. These are called as denosumab. Denosumab. Now to understand about denosumab, first we'll try to understand. This is osteoclast. On the surface of osteoclast, there is presence of a receptor which is named as rank. Rank is the receptor present on osteoclast. So whenever the ligand bind to this receptor, whenever rank ligand, it bind to this receptor, it will stimulate the osteoclast and that will lead to resorption of bone. So this is the normal thing. So whenever rank ligand bind to rank receptor on the osteoclast, that lead to resorption of bone. Okay. Now, if we give a monoclonal antibody, denosumab is a monoclonal antibody against this ligand. That means denosumab, it will bind to rank. So when denosumab bind to rank, now it is not available to bind to rank. So denosumab bind to rank ligand. So this ligand cannot bind to rank. So when rank is not stimulated, now resorption will not occur. Yeah. So in simple language, you can remember denosumab inhibit osteoclast. Simple language, denosumab inhibit osteoclast, and from the name you can remember it is a monoclonal antibody used in osteoporosis. Denosumab. Okay. Then we have a drug which is called as strontium ranelate. Strontium ranelate is a drug which has dual activity. Dual activity means, till now we discussed some drugs, they act by stimulating osteoblast. Only one drug in fact we discussed, teriparatide. Some drug which act by inhibiting osteoclast, like we just discussed denosumab or bisphosphonate or even estrogens. Strontium ranelate has both of these actions. It not only stimulates osteoblast but also inhibit osteoclast. So this action, dual action, is present in strontium ranelate. But the problem is it increases the risk of thromboembolism, so it is not commonly used. But important MCQs, which drug has dual action? It is strontium ranelate. Okay. The next drug is romosozumab. Another monoclonal antibody. But before discussing romosozumab, we need to know there is one endogenous substance called as sclerostin, osteosclerostin, normally present in the bone. This has two effects which we do not want. Sclerostin is involved in inhibiting osteoblast and in stimulating osteoclast. That means exactly two factors which cause osteoporosis. Inhibit osteoblast, stimulate osteoclast. So we do not want this. So we want that osteosclerostin or simply sclerostin should not work, because this is working to promote osteoporosis. So what we have done is we have developed a monoclonal antibody against sclerostin. So romosozumab is a monoclonal antibody against sclerostin. So it can be used in osteoporosis. So like strontium ranelate, it also has dual action. Yeah? So again, from the name you can remember, monoclonal antibody used in osteoporosis, romosozumab. Okay. Then we have last group of drugs which are called as calcimimetics. Calcimimetics. So as the name tells, they mimic the action of calcium. Calcimimetic. Now before going to these drugs, we'll try to understand some important thing. This is a parathyroid gland. Parathyroid gland. which contain parathyroid hormone. Now, what is the most potent stimulus for release of PTH? Now, to answer this question, in fact, for answering any question on stimulus for release, we should know the function. What is the function of PTH? It is to increase serum calcium. So, whenever serum calcium is low, PTH should be released. So, whenever hypocalcemia occurs, serum calcium is low, PTH is released. Or in other words, we can say if calcium is normal or high, PTH is not released. Or we can say calcium is inhibiting the release of PTH. And how it inhibits is, on the parathyroid gland, there is presence of a receptor. The name of the receptor is calcium sensing receptor. The name says CASR, calcium sensing receptor. So this receptor is sensing the blood calcium. So whenever this blood calcium is present in adequate amount, then calcium will stimulate the calcium sensing receptor. And when this receptor is stimulated, now PTH cannot come down. It inhibits the release of PTH. Clear? Now, in patients with hyperparathyroidism, if there is hyperparathyroidism, we know it will increase calcium. Hypercalcemia will be. But hypercalcemia should automatically inhibit the release of PTH. But this is not happening. This person is having hyperparathyroidism as well as hypercalcemia. And when hyperparathyroidism occur, osteoporosis occur. That means bone calcium will be liberated into the blood. So problem is, when calcium increase, it should have stimulated the calcium sensing receptor and inhibit the release of PTH. But that is not happening. So when calcium is not able to stimulate calcium sensing receptor, so we give a strong drug which stimulate the calcium sensing receptor. If calcium sensing receptor is stimulated, PTH will not come, so osteoporosis will not occur. Yeah? So we can use calcimimetic drug, calcium sensing receptor agonist, for the treatment of osteoporosis due to hyperparathyroidism. Okay, and this drug is Cinacalcet, and a new drug etelcalcetide. Cinacalcet and etelcalcetide. So their name also contain cal, means calcium. Cals means calcium. So calcium sensing receptor agonist. So these are stimulators of calcium sensing receptor, and they are indicated in osteoporosis due to hyperparathyroidism. Okay. Now quickly we will revise the drugs which are used in osteoporosis. Which drug act by stimulating osteoblast? Which drug act by inhibiting osteoclast? And which drug has both the mechanisms, dual mechanisms? The drug which stimulate osteoblast, first is parathyroid hormone analogs. That means teriparatide and abaloparatide. Then drug having dual actions, it includes strontium rhinolate and romosozumab. And all other drugs inhibit osteoclast. All other means even estrogens, SCRMs, bisphosphonates, denosumab. So all other drugs inhibit osteoclast. So only 3 drugs stimulate osteoblast. One is teriparatide group, second is strontium group, third is romosozumab group. Clear? And out of this, strontium and romosozumab inhibit osteoclast also. Okay. So these are the important points regarding the osteoporosis. Thank you.